between. So I will taking up the first topic, which is autoimmune encephalitis, and the last decade has actually changed practice of neurology. And I think the whole gray line between neuropsychiatry and psychiatry and neurology has really changed ever since we've been able to diagnose more and more autoimmune encephalitis. These are very complex disorders, and you need to have a very high index of suspicion to diagnose them. And generally, will be of two types. They will be either idiopathic or they will be related to an underlying malignancy. That's the one core point for the students. Many of these diagnoses are missed. They end up in psychiatry wards and they don't get appropriate treatment, immunotherapy, which is the key to success story in these patients. So let's start with this history. So this was a lady who was related to one of the faculty at AIIMS New Delhi. She is a 32-year-old teacher, and she was apparently doing very well. And then she had felt a state of anxiety after the death of a close neighbor, a neighbor's family. And they thought probably, she is just anxious by the way. There was no change in the behavior in the beginning, and she was admitted to an academic hospital because she was really, really very anxious, and they felt this is not usual for her. During this period, she also had these few episodes of incontinence of urine and stool, which obviously was something to get worried about. So she was treated when she started having new onset seizures, and diagnosis of enteric encephalopathy was made because her Vidal was somehow positive. Now that's not an uncommon diagnosis in our country. Everyone has enteric fever until proved otherwise. So she would resist medication. She became more and more apprehensive, and then came to our center and was admitted under neurology services. She was conscious but not oriented to time. She would occasionally recognize the husband. She was irritable, extremely fearful, and would not allow physical examination. And she would walk without support. Now, there are a few investigations, and I will go back to back in this case over the next few slides. So, this is the cell part of the human body. And this is especially for the students. In the center, you have the nucleus, and around that you have the nuclear membrane, and of course you have the cell surface. So there are few antibodies which directly affect the cell from within. And those important antibodies, please remember the antinuclear antibody 1 and 2, YO, GAD, CRMP5 and MA2. Now just remember those names because you have to remember them. There is no option because they have been quoted based on some important algorithms. Now, there are important, antibodies which actually play around the cell surface of the cell. And these cell surface antibodies are very critical, and one of them is the LGI1. I will talk about that. These are leucine-rich glioma, inactivated 1 protein antibody. Then the contactin-associated antibody, which is also called the Casper2. Why I'm telling you? Because when you order the autoimmune encephalitis panel, you'll get this list which you will then see whether my patient has positive or not. And then, of course, we have the MOG and aquaporin, which I will be talking about in my further coming talk. And then there are these special antibodies, which are at the place where two cells. So these are the synaptic antibodies. In the synaptic antibodies, you have the NMDA receptor antibody, which is like the one of the most common forms of autoimmune encephalitis. You have the GABA receptor, and you have the dopamine 2 and the metatropic glutamate receptor 5, that is the mGlu-R5 antibody. Remember the most common, NMDA, remember LGI1, remember Casper2, remember GABA. If you remember these 4, you're done for the day. Rest of them are not very common anyway. So if you look at this placed in the right order, you'll see some of them coming right out of the cell nucleus, coming inside the cell and then on the surface of the cell, and that's how they actually are when they have been documented as these structures. Now, if you look at this diagram, and I've also showed you that these particular antibodies, if you look at anti-HU, anti-GAD, and anti-MA2, these are generally to intracellular antigens, and they present typically mostly with encephalitic pathology. And one of the important encephalitic pathology is called the limbic encephalitis, which means it involves the limbic part of the nervous system, which connects memory and personality. So always any patient coming to you with changes in memory, new onset, personality, behavior, think of a limbic encephalitis syndrome. That's my key point to all of you. So what are the features that would make me suspicious as a clinician? My first feature would be a subacute onset or a very short history. Don't deny short histories. Don't send patients to psychiatry. Make sure you have made the correct diagnosis. Look at the new onset neuropsychiatric abnormalities. Number 3, especially the memory disturbances. Number 4, cognitive impairment. Number 5, new onset seizures, bad ones, which are like abrupt from the bold, from the blue. Of course, I'm not saying you won't rule out neurocystic psychosis and all that. Of course, tremor and then some peculiar movement disorders, which I will show you, sleep disturbances, fluctuations, and of course, imaging findings. I would say the key point to that is a short history in psychiatric abnormalities, seizures, and fluctuating course of a patient. If you see any of these in the new onset patient, think of an autoimmune encephalitis. Now, I placed this pie chart for all of you, an overlap chart. So if you have behavior, if you have memory, if you have cognition and seizures, especially starting in the middle age to the late adult, think of a limbic encephalitis. And limbic encephalitis includes a very important encephalitis called the voltage-gated potassium channel antibody, which is called the VGKC antibody. If you see a patient, a young patient, especially a female, I'm again reiterating, especially a female, with behavior, psychosis, a lot of dystonia and seizures, think of NMDA receptor antibody encephalitis. If you think of an elderly male who is presenting to you with behavior, memory, peculiar movement disorders, which I'll show you, and hyponatremia, think of LGI1 antibody. If you have someone presenting with neuromuscular disorder, new onset, myotonia, presenting with extrapyramidal fasciculations all over the body, think of Casper-2. So if you look at this whole thing, there'll be a bit of an overlap, but you need to be a good clinician to really filter out all of that when you take a good history of your patient. So that's the key point. Now, these are the diagnostic criteria. I won't go much into the detail. It also talks about subacute onset, presence of focal CNS findings, seizures, and CSF abnormalities. These are quoted as one of the diagnostic panel by a group which published in Lancet in 2016. So this is the kind of a graph that you will tend to see in your patients. Generally in the prodromal stage and in the middle stage, you will see a lot of psychiatric and cognitive problems to start with. As it evolves, you'll start seeing movement disorders and seizures, and then reduced consciousness as the disease. The green bar is for reduced consciousness. The mauve bar and the blue bar is for cognition and psychiatric, and the deep blue bar is for seizure. So if you look at this whole pattern in these patients, these 3 bars really direct you towards a good diagnosis, behavioral change, new onset seizures, and then deteriorating consciousness and movement disorders. So I placed this for you in a small, bar chart. If you look at seizures, they are more common with LGI1 and Casper, especially if you see for students. There are these specific focal, short-lasting events called facial brachiodystonic seizures. वो ऐसा होता है, इतना ही होगा for just 2 seconds. And the family will say ये बार-बार हो रहा है इनको, and he will be having this behavior change. So it is like the face will go one side, the hand will go on one side. That's it. These are typically called facio-brachiodystonic seizures on one side. Very short lasting, very brief, and I'll show you a video of another patient in the few time. So if you look at in LGI1 and Casper-2, you have a prominent features of amnesia and personality change. If you see in patients who have Casper-2 and LGI1 negative, you will see less and less of these. But if you have a patient who has neuromyotonia, dysautonomia, muscular disease, this is much more highlighted in patients with Casper-2 antibody. So just remember these few things when you are trying to, trying to find out a diagnosis. So I've just again placed atypical demyelinating syndrome, psychiatric disorders, new onset, status epilepticus in your emergency, which is just not getting controlled in a young woman. MRI kara liya, sab kara liya, kuch nahi mil raha. And then you have this uncertain encephalitis, viral infection or a cancer, all of this will eventually play a part, which causes alteration of synaptic function in the brain. And that's where the whole problem is in autoimmune encephalitis. That's where the whole problem happens. So it's good to be clear, young ladies and gentlemen behind. You will have to think of a syndrome first clinically, look for a specific antibody that you want to direct your attention, and then look for the cause which is causing it. Is it idiopathic or is it due to an underlying malignancy? Because most of these autoimmune encephalitis may have a streak of underlying malignancy, especially if the antibodies are paraneoplastic type. So always look for a good history detail. And as ma'am had also suggested, a good clinical history is very, very key in these patients. Take a thorough history of when it started, any recent infection, seizures, personality change, opportunistic infection, travel history, screening for occult malignancy, and so on and so forth. Take a detailed history of these patients, like routinely. How would I generally evaluate? Imaging, blood work, EEG, a psychiatric consult if I'm uncertain, and a PET if I feel the requirement because I want to rule out a malignancy. Now, we have a blood work which is very routine. You will always do a hemogram, biochemistry, ESR, CRP. You may send for vasculitis profile, toxic screen. It all depends what you're actually aiming at the diagnosis, especially a new onset behavioral syndrome. So you'll always look for everything. Now, the important part is the antibody detection. If you're strongly contemplating, then you need to send a cell-based assay because that's the most sensitive form of the assay. You also have ELISA, we have radioimmunoassay, and always, preferably, if cost is not an issue, it is good to do a CSF and a serum paired. Because sometimes you will get a serum positive and a CSF negative, or a CSF positive and a serum negative, depending on the sensitivity of that particular antibody in that serum and the CSF. So it's better to send a paired sample. I know it adds on to the cost, but I think this is an important diagnosis that we need to make. So if you look at this top chart for all of you, most of these antibodies, NMDA antibody, VGKC antibody, LGI1, Casper2, are generally well detected by a cell-based assay. Most of them will be covered. However, sometimes if you may need, for example, a VGKC antibody, you may need a radioimmunoassay also. So there are few of them which may need a radioimmunoassay, but otherwise what you're sending commercially you are sending this autoimmune encephalitis panel, they're all actually cell-based assays. So there should not be a big issue about that. CSF, yes, surely will do. Has to be done to rule out infections and other causes, which we will send for complete detailed evaluation. And for students, it is very, very important that CSF is a pristine and a very precious investigation. Don't think it's a blood count. कि आप 25 बार कर लोगे. Plan your CSF in advance, write down in your file, mention all the things you want to send, cell, protein, sugar, malignant cytology, infectious workup, whatever you want to send. Send planned CSF in these patients, because if you are wrongly diagnosing autoimmune and patient has a tubercular meningitis, and it's a bad deal. So don't do that. Always send for a malignant cytology. You could also have a carcinomatous meningitis and for an antibody panel. Of course, that's important. Now, imaging is peculiar in these cases. In NMDA receptor encephalitis, predominantly more than 90% will have a normal MRI. And that's the beauty of this disease. The MRI is normal, patient is extremely abnormal. So don't think कि इसको कुछ नहीं है. And that's where autoimmune encephalitis misdiagnosed and is less diagnosed if you are having an uncertainty. And there are specific patterns which you should be seeing. Now, if you do an MRI and you find on a FLAIR image or a T2 image, these typical hyperintensities in the medial part of your temporal lobe, in a patient presenting with new onset neuropsychiatric disease, this is pretty suggestive of what we call the limbic encephalitis. This is classic, if you find that. Okay? NMDA may be normal and it generally is the dictum. Rarely you may find these peculiar cortical hyperintensities which are scattered all across the brain, but that is very rare. I mean, I haven't seen in any of my patients, honestly speaking, till now. If you see a young male presenting with behavior changes and typically involving the diencephalon, which means the suprathalamic portion, the mammillary body area, patient is confused, misbehaving, sexually distorted, everything. Think of what we call the MA2 encephalitis, because that is typically seen in young males and is associated with seminoma of the testis. So always think of MA2 encephalitis if you see such kind of pattern. And if it is progressively getting worse, this is another form of that same. And we have seen few patients like that. So always look for these typical changes that will affect typical parts of the brain. That's important. So let's get to back to the patient. She was conscious but not oriented, I said. So what investigations we did? We did a hemogram, we did a biochemistry, we sent a detailed CSF, which was absolutely normal. EG was normal, PET was normal, MRI showed classic limbic hyperintensity, serum NMD antibody was strongly positive. So this girl, a young female, a teacher who was thought to be having the stupid enteric encephalopathy, had a classic picture of NMDA receptor encephalitis. So this is her MRI, ladies and gentlemen. She had this typical limbic encephalitis, small cortical hyperintensities in the frontal plane. And this is the MRI on follow-up in August and in January 2019. Back to work, absolutely normal, never had a relapse. And absolutely cleared of MRI. So that's the beauty of if you treat these patients on time. So this is for the students. This is another lady who came to us, brought by the daughters, that my mother is kind of not looking normal for the last 1 month. They thought there was some problem in the family, financial, and that's why she's doing it. And this is her video. Carefully look at what's happening to her. You saw? ऐसे ही होता है बस. And this was happening frequently to her while she was talking to us, sitting, lying in the bed, and the family was not sure why this is happening. I can play it again for you if you want. And this is important for the students because this is what is called the facio-brachial dystonic seizure. See, like face gets dystonic, hand, and she would look at her fingers and not know what is happening. This is classic. If you see this, there's only one diagnosis. LGI1 antibody. That's it. There's no differential diagnosis in these patients. And if you do a EG, and you find this typical pattern, what is called the extreme delta brush sign. The delta waves will look like a brush all over. This is classic of NMDA receptor encephalitis. So if you want to do an EG, you need to know what you want to look at the EG for. You want to look at active seizures. You want to look at patterns. You want to look at extreme delta brush. This is called the extreme delta brush sign of NMDA receptor encephalitis, which is classic for it, and it is very strongly associated with these patients. So I think this is a pretty not looking very good slide. I'll skip it. So do we look for a malignancy? Yes, I would look for a malignancy because I want to be sure. I have this extreme of age groups, young people, middle age, and the elderly. So I will be look out for most of these disorders, or I will also look for a follow-up of these patients because they may need a repeat PET scan in some of these patients. So I've drawn this diagram, and not drawn, I mean I've taken it from an article. So if you look at intracellular pathologies like anti-Hu, CV2 and MA2, they are very strongly paraneoplastic. You must have seen, and students must be reading anti-Hu antibody syndrome, which is specifically associated with small cell lung cancer. Patients that develop neuropathy, neuronopathy, behavior change, and can be very misleading in the diagnosis. And then you have these typical membrane Casper. I showed you NMDA receptor, contactin. They can be commonly paraneoplastic. But some of these membrane and intracellular like LGI1 and GAD are very uncommonly paraneoplastic. So that is important because you may like to repeat a PET scan on follow-up. So you can have a fair idea based on what the literature shows, which is definitely more paraneoplastic, which is less, and which is least likely to be paraneoplastic. So this is what I have drawn for you. In NMDA receptor encephalitis, there is one thing which will affect the females. That is ovarian teratoma. Never miss it. Don't send a female without an ultrasound of the pelvis or a PET scan. That's the dictum number 2. You will miss a teratoma. This has to be removed. There's no question. So ovarian teratomas, LGI1, although it is rare, but is associated with thymomas. That is important. Number 3, the Casper2, again associated with thymomas because I told you they have neuromuscular disturbances, neuromyotonia, fasciculations and all that. In patients with 2, this is a seminoma of the testis, which is very strongly associated. In GAD antibody, it is associated generally with small cell lung cancer, so you have to rule that out. In GLU5, again, you are associated with what is the Hodgkin's lymphoma, so you have to make sure that you've ruled out a lymphoma. And of course, in M body, you can associate many small tumors, chest tumor, thymoma, or a breast cancer. Antibody, again, lung cancer is very commonly associated. So this is the typical scenario of associated malignancies in patients who have autoimmune, and keep a watch of that. So screen for your lungs, screen for your pelvis, screen for your chest. Now that's very simple. A PET scan would. Now this is the ultrasound pelvis in February 2019 of another female who presented to us, showed an ovarian teratoma and was removed surgically. So don't miss diagnosing. So this is one particular review which clearly suggests is the for malignancy. And if you see that tumors are present in GABA more commonly, AMPA receptors, ovarian teratomas in women. But you know, in LGI1 it is very rare. In Casper2 mostly thymoma. So you know that you will screen some of the patients very intensively. I'll come to the last few. I have 5 more minutes. Okay. So because I thought this is important for the students. So there is something called the NORS and the fires. And this is this slide courtesy is from one of my residents who presented a recent seminar on this. So NORS basically is new onset refractory status epilepticus. You will see a 20-year-old walking to your ER, bad status epilepticus, CT normal, EG showing only intermittent ongoing status epilepticus. You did every damn thing. The status epilepticus just doesn't get controlled. It is super refractory in most of these patients. So the NORS can be associated with many findings, and one of the conditions is an autoimmune epilepsy, which means it's an autoimmune cause for this triggered seizures. The fires is a subcategory which has a past history of or a prior history of infection, febrile infection, and generally starts between 2 weeks and 24 hours prior to the onset of refractory status epilepticus. The NORS is something which is potentially could be associated with an autoimmune cause for epilepsy, which means, so what are the clues? You start with status epilepticus or a flurry of seizures. You have a resistance to whatever you are treating. You are having an onset generally after 30 years of age, and you may be having an associated autoimmune disorder, maybe even just rheumatoid, lupus, we don't know. EG shows an extreme delta brush. All of this, if it is present, like T2 signal which I showed you, all of this in a new onset status epilepticus should raise a doubt in your mind that I may be dealing with an autoimmune encephalitis or an autoimmune cause for an epilepsy, seizures, the new onset seizures. So these are a few points that will help you decipher that. And for students, this is something called the APE2 score. If you look at the score, it says new onset rapidly progressive mental status changes, give 1 point. New onset autonomic dysfunction, give 1 point. Neuropsychiatric symptoms, give 1 point. History of underlying malignancy in the past, give 2 points. Viral illness, give 2 points. Like that, if you see the seizures I showed you, the faciobrachial seizures, dyskinesias, high CSF protein, and if MRI shows you abnormalities in the temporal lobe, all of these add up. And if you find that the score is clearly more than or equal to 4 or 5, and as the score goes up, with these elements in the history, which is pretty intuitive and logical, you will probably have a high chance that this patient has a autoimmune cause for his new onset status epilepticus. So you can keep these all points as a checklist only. I'm not saying don't even use the score. I think as a good history taker, you will ask for everything, which is pretty intuitively logical. So I really don't have to drive to that. So this is the algorithm for predicting autoimmune epilepsy. If you have an unknown etiology, you do the score, you investigate. If you find an antibody, do the immunotherapy. If you don't find the antibody, you look for a specific syndrome, but your treatment will be with the immunotherapy trial. Eventually, if you're strongly contemplating whatever you may do, your seizures or status will never get fully controlled. Patient is not going to wake up till you treat him with immunotherapy. That's the key point. That's why I'm stressing that you need to be certain that you are not missing an autoimmune cause for a new onset seizures. So how do I manage? I mean, how do we all manage? Acute phase is intense immunosuppression. So in the intense immunosuppression, we'll come to that. This lady we came back, she was started with IB-MPS and was given IVIG pulse because the family was very resistant or very apprehensive of doing plasmapheresis. Our first choice, and I don't know, most of, I think, immunologists' first choice for these patients who do not respond to steroids. And we don't wait and watch. कि 10-15 दिन बाद देखेंगे steroid का effect क्या आ रहा. Never do that. Even the next 5, 6 days, 7 days, you're observing patient is not improving. Just start with plasmapheresis. That should be your treatment of choice. If plasmapheresis is not available, the patient has a contraindication, straight away start IVIG. You cannot wait in these people. And we have evidences to clearly suggest that if you follow this algorithm, that you have a diagnosis of autoimmune encephalopathy, you give acute treatment, steroids, or IVIG, or plasma exchange. This is typically done in a progressive fashion. It's not that steroid दिया, 15 दिन wait किया, देखा अच्छा ठीक नहीं हो रहा, अभी कुछ करते हैं. Not like that. It has to follow successively early in the course of the treatment. And if that happens, there is no improvement, then you have to think of a further immunomodulation. And the further immunomodulation, generally what we tend to prefer is IV rituximab. That's a preferred with most of the immunologists across the world. Rarely you may also give cyclophosphamide. They are young people. We don't want to let them have some, unfortunate, sterility. So we prefer rituximab. So if you're not showing benefit with plasmapheresis, 15 days, 20 days have passed, patient is not improving, start rituximab. You may have to start rituximab if your clinical judgment suggests that patient is really not improving. Movement disorders are continuing, patient is sick, still getting ventilated. You need to go up the ladder, not down the ladder. And if substantial improvement happens with this only, then you need to decide for long-term steroid therapy or immunosuppressive therapy, depending on what you decide what the patient is likely to relapse with. That brings us to the second point of what are the prognostic factors in NMDA receptor encephalitis. If you look at this, this is a graph which shows you 1, 2, 3, 4 patients. If you see those patients in whom their treatment was successively introduced early, they did better. In patients who treatments were induced successively but slower, step by step, they did not do well. And if you look at these color-coded graphs, the 0 means that in the white bar means that you have recovered to a very good extent. As the red bar is increasing, it's death. So on the we say this is a Rankin score. 0 is no disability, and as you go up, number 6 is death, 5 is disabled on bed, and we want patients to be 0, 1, or 2 because they will be independent at that Rankin score. So that's what it happens. And if you look at this paper also, if you have given only first-line immunotherapy, and there are people who are not improving, and if you've added second-line immunotherapy early, the green bar, they tend to remit and remain stable for a much longer time. So that's a decision that you may have to take based on independent decisions. So this is the typical way patients are going to improve, and that's why I'm going to show you this graph, because when a patient is in your ICU, you get very panicked why the patient is not improving, not improving, not improving. So you will start with a prodrome phase. In 1 to 2 weeks, patient will come and he'll be landing up with you in an altered sensorium, even in comatose state. Then you start treating, and of course over months to years, they make slowly and steadily good recovery. But in patients who are not treated and in patients who are, not treated appropriately intensively, there is a good chance that your patients may be left with significant sequelae. And that's not uncommon with these disorders. That's important point. So there is a NEOS score which was brought out for NMDA receptor encephalitis. If you have a patient who needs ICU admission, who's very sick, he has lack of treatment within 4 weeks of onset, which means patient's treatment was delayed because the diagnosis was delayed. And lack of clinical improvement within 4 weeks of starting treatment, a bad MRI brain, and persistent leukocytosis. This is called the NEOS score from 0 to 5. If you look at as the score increases, the chances of this patient's long-term good outcome reduces. So these are scores. I mean, I mean, no, I'm not saying put that goddamn score in every damn patient. It's not necessary. But this gives you some idea how your patient will do over the long term. So this is a score which was specifically made for NMDA receptor encephalitis. So probably may or may not be useful for all other encephalitis. And this is the typical clinical course which I've just showed you, even for the Casper-2, because there you have a lot of hyponatremia. That's why I put it. Again, they follow the same pattern of come and go slowly over a period of time. So long-term treatment, there is a debate whether you should immunosuppress patients for long-term. Honestly speaking, most of us neurologists, and when we see such patients who have taken a long course of recovery, prefer to give at least, even though not lifelong, but a medium to long-term immunosuppression, because there is a risk of a relapse. And there are two specific, if you look at back to this busy slide, but don't look at the busy slide part because I've already told you most of it. There are tumors which are associated and you have to remove, then they will get better. But look at the relapse rate. In NMDA receptor, it is between 12 and 25%, and this keeps on varying in literature as new data comes in. It is uncommon with LGI1. And in Casper-2, we have limited experience because data is not that huge. And in EMPA receptor, it is 50 to 60%. In GABA, it is uncommon. And in glycine, again, the data is very minuscule. So if you're seeing NMDA receptor encephalitis, or you're seeing a patient with EMPA receptor, they definitely have a strong risk of recurrence. So preferably immunosuppressing them for at least few months to maybe a year or two may be reasonable. In the meantime, you will repeat a PET on follow-up and see if there is another tumor which was missed, and you will do successive PET for at least the first 2 years. I generally am wary about doing PET scans too much because it's a lot of radiation exposure in young people. So you can stream down it to a pelvic ultrasound and others which can be less radioactive. But, you know, in LGI1, although it's uncommon, when you see a very elderly person who presents like this, I have generally preferred to immunosuppress them for almost a year to 2 years and then slowly taper down if they are doing very well, because long-term recurrences are not very huge in these patients. So you may have to find a reasonable idea to make sure that your patient may require, potentially most of us tend to immunosuppress for some time because it is better to do that. So in this lady, she was just given steroids and the family was not very comfortable in long-term immunosuppressions. We gave steroids for a lengthy period, then we tapered them very, very slowly. Residents, please don't do 50, 40, 30, 20, 10. That's crap. In none of the immunological diseases, we follow this algorithm. The algorithm is persisting with steroid. Most of the effect has been happening. Patient is in remission, and a slow titration over a period of 6, 8, 12 weeks. Please follow that regimen for these patients. And this lady has been doing very well, and she's had 2 PET scans on follow-up. And of course, this was a dermoid which was eventually removed. So I think that's my last slide. It's a very important emerging evidence of cognitive disease in both young, middle, and the elderly population. Remember to keep these things in mind and have a very high index of suspicion. If you don't have it, you're going to refer this patient from the OPD to psychiatry. That's for sure. And that's why I'm telling you, autoimmune encephalitis has blurred those boundaries when people were sent with these behavioral changes. In young people, make sure, I'm not saying you become paranoid ki har ek ko banana hai, but just keep that wisdom in your mind. Look for a malignancy, and the most important point, investigate early and treat early. If you delay these people, I can tell you the sequelae can be really, really bad. Thank you, Atuluk, for this opportunity to speak.
So, if there are any questions, or we can break for tea and come back. But most of these patients, I mean, since you tapered steroid over 4 months, I mean, or would you shift them to some, steroid like mycophenolate, which is a better tolerable drug? And
most of us prefer to give them immunosuppression. I personally prefer azathioprine, or mycophenolate is good, but I have a more belief in azathioprine because it has a long experience. If the patient has already been given rituximab, then we know that patient's got a immunosuppression for at least next 6 to 7 months, and we need to decide whether the patient is now going to be requiring a long term or not, because I showed you that relapse rates are not in every form of encephalitis. But as a decision making, if you think that I would prefer to immunosuppress, then you will start it in the beginning only, of course. And by the time steroids are tapered, the immunosuppression is
Will
already
take.
there.
Yeah.
Of course, same pattern. Like we do for myasthenia, anything, same pattern.
Welcome, sir. You came by same flight, but you're late.
Very nice talk as usual. Recently reports have also shown patients who have been diagnosed as Alzheimer's disease, but they have been rapidly progressive. So they should also be investigated as autoimmune encephalitis and not being labeled as the senile, or because that's a treatable disorder.
That's a good point, but hota kya hai ki in the haste, I mean not in the haste, I would say, in the whole sensitivity to make more diagnoses, you will make everyone autoimmune encephalitis. But I take your, that's what I said. If you see a person with a relatively short history, a new onset history, please take all these clinical points into that. And as you rightly said, investigate them for autoimmune encephalitis. So we typically say that less than 2 years is an early onset dementia, and 6 months is rapidly progressive dementia. Rapidly progressive dementia, this is a strong differential diagnosis. You have to investigate. There is no question. You can't miss it. It's a treatable cause. You're very right.
Yeah, because
No, I didn't want to really. I know. So, as Vinay said, I can tell you that there has been some reports where herpes simplex encephalitis can potentially trigger the development of autoimmune encephalitis. Now, for me, this is not really out of the box thought. It's a good thought which people found. Any encephalitis is going to cause synaptic dysfunction, loss of neurons, and what triggers in the internal milieu as a recovery phase, we really don't know. So these associations, of course, are there, and HSP, post-SSP, you could have a relapse of HSP, you could develop NMDA receptor encephalitis. You rightly said that.
yeah, very. I mean, because we recently we are having a patient, young girl, exactly similar presentation, refractory status epilepticus with some cognitive distress, short history.
Norse.
So basically, and we give MPS. Beyond that, IVIG. I mean, patient could not. I mean, we are still trying to wean her off. So the take-home message: you should be more aggressive. Actually, your immunotherapy should be.
Immunology has two dictums. Be aggressive at the right time and be less aggressive at the right time. So you need to decide where aggression is needed. And in these patients, you need to be very aggressive. These are very, if you look at some of these patients, they are so bad. We had a patient who's been with us for almost 8 weeks. We've done IVIG, Plex. We've done all triple therapy, Retux. She's now settled, but she had such bad movement disorder, bruxism. We had to give her Botox. They had lots of issues, and they can be really, really bad. So, these are very peculiar diseases. I think immunosuppression at the right time is a very strong point. It's a very strong.
Thank you very much, sir. So nice presentation. Let's break off for a coffee, then come back.